Okay.
Good.
So I have two cases. I'm going to go through them quickly. The first one's a 60-year-old man with osteoporosis, vertebral compression fractures, and tibial plateau fracture. He has a history of hypercalciuria, but no known history of stones at that time. He's thin. His exam is okay. His T-scores are minus 2.8 to 4, and he had been treated with 12 months of teriparatide. It was stopped short because his urine calcium went way up, and he was given 2 doses of ZA. His chemistry panel was okay, except the calcium was at the upper end of normal. His urine calcium is high, parathyroid level low normal. Our normal goes about 15. Phosphorus 2.1 and to 2.6, all in that low normal to slightly low range. The 25D was normal. The 125D was higher than one might expect given the absence of PTH. And FGF23 was normal. And when I assessed his renal phosphate handling with a second fasting urine and simultaneous blood, his TRP with a phosphorus of 2.2 was 0.8. So that's low. He was only absorbing 81%, reabsorbing 81%. And that correlates to a TMP GFR, which was 1.9, which was low. And so we sent him for genetic testing, and as suspected, he has a heterozygous, I'm sorry, mutation of one of the sodium phosphate transporters that Peter mentioned. And if you have this, you waste phosphorus, that stimulates 125D. Remember, it's FGF23 independent. That raises calcium absorption, so you get you 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 lower the PTH, and the combination of increased calcium absorption and low PTH causes hypercalciuria. And if you have two copies of that gene, you get hereditary hypophosphatemic rickets with hypercalciuria. This is a paper just published, and as you'll see, Peter is one of the authors. And what they found was that the homozygotes have HHRH, and the heterozygotes can have a renal phenotype with calcifications or a bone phenotype. And you typically treat these people with phosphate. And so I did renal ultrasound. He does have some stones, and we're evaluating the family and planning phosphate treatment. But this patient I saw for the first time 3 days ago. Hypercalcemia. She's 57. She's had it for at least her early 40s and maybe younger. She had stones start at age 6 and then again age 20. Past medical history is non-contributory, as is family history. She's ethnically Irish on both sides from different parts of Ireland, and there's no known consanguinity. She's not had bone disease or rickets. On exam, she's 5'9", 195 pounds. She has no bowing or pretibial tenderness. Her calcium levels are 11 to 12.4 with slightly elevated creatinine, urinary calcium 400-ish, PTH levels mostly in the upper half of the normal range with mild hypophosphatemia, dead normal ALK phos. The 125D is high and PTHRP normal. So she had imaging, which was negative. It looked like primary hyperpara. She did have possible nephrocalcinosis on an ultrasound, but parathyroid imaging was negative. They took her to parathyroid surgery, and what they found was no decrease in the intraoperative PTH. They removed at least 2 glands, and they were upper normal in size. I'm not sure if a third gland was removed or not, but there's absolutely no change in her biochemistry. And they sent her to genetic testing, and they actually did the stone panel rather than the parathyroid panel. And what they found was that she was homozygous for the same pathogenic mutation of this NAPI2C. She had pertinent negative genes, ALK phos, FHH1, dent disease, CYP24A1, 24-hydroxylase, and FHH2. These MEN1, 4, and FHH3, as well as some other familial hyperparathyroid genes, were not tested. So this is the way I looked at HHRH. I would not expect the blood calcium to be that high. I would expect rickets, which she clearly doesn't have. I would expect a low normal PTH, and the high normal PTH with hypercalcemia seems more consistent with primary hyperpara. So the question I have is, does she have something modifying expression of the disease? What my plan is to evaluate renal phos handling with a TMP GFR, the second fasting urine, and so forth. Do a little more genetic testing, evaluate family members. But what am I missing? And it also seems awful weird that she has a homozygous mutation for this gene, unless there's some founder effect in Ireland or something. I don't know. So I think I'll stop there. It doesn't go together easily, for me at least. Peter, did you want to comment?
Yeah, well, you always have extremely challenging cases. I agree with you. The biochemistries don't fit with just a sodium phosphate transporter defect. As you pointed out, the PTH is higher than we'd expect it to be. Although when you look at the data from the Clemens-Bergwitz study that you had cited, he collected, I don't know, 220, 230 patients from the literature and other centers. PTH values in the patients with two abnormal alleles could get up in that 30 to 50 range for some of them. But as you pointed out, the serum calcium a bit higher than you'd expect. Um, and so the full story doesn't fit. The fact that she didn't have, I think you said she didn't have rickets before, or really a significant bone phenotype, maybe 30% with homozygous mutations don't seem to have a bone phenotype, and they
Okay.
present mainly with the renal hypercalciuria. And so I like your approach to look at the rest of the genetics. Gosh, that's, really unlucky if she's got a rare hyperpara syndrome along with this sodium phosphate transporter defect.
So, Peter, that helps a lot. And I have a follow-up question because I thought about this. Um, Why, so I've seen, and in your paper with CYP24A1s, and in
Mhm.
one of my, I have like five patients with CYP24s. One of them has PTHs 30 to 40, maybe even a little higher. I can't remember, despite calciums of 11 and a half.
Mm.
And and in your paper, I remember I think it was in Journal of Endocrine Society, maybe I can't remember.
Mhm.
And one of those patients had a PTH in the 30s. And it just doesn't make sense to me. It
Yeah,
seems like it should be suppressed.
I agree. If the serum calcium is high, it should be suppressed unless there's a secondary issue going on. Now, with treatment, and when I say treatment, I mean low calcium, low vitamin D intake, maybe limiting calcium intake to
Right.
40 or 50% of the usual daily intake. Oftentimes that PTH will come up into the lower part or the mid part of the normal range, but if they still have hypercalcemia and that PTH is not low, then there has to be a second issue causing that PTH to be high, like hyperpara. I have seen one patient that developed tertiary hyperpara and had a CYP24A1 gene mutation, but this was in the context of end-stage renal disease and then ended up with a kidney transplant. So those waters were very muddied by a bad kidney disease, raising the PTH as well.
So do you have any other diagnostic ideas?
From a diagnostic perspective, no, I agree with rounding out the hyperpara syndrome entities. It's possible there's still primary hyperpara and just the offending gland wasn't identified. Um, from a treatment perspective, what were your what
I hadn't even got there. I mean, I don't know if
you
how,
just saw this
I'm a little
patient a couple
reluctant to
days
give.
ago.
Yeah, I'm reluctant to give. I mean, I don't know how much phosphate I want to give to somebody with calciums of 11 and a half.
Right.
And she's got
Right.
no, I mean, really, her only problem is the hypercalciuria.
Mhm.
Uh, and I'm probably not going to give her a thiazide. I don't know. I hadn't thought about it. I
Yeah,
hadn't
your thiazide's going to make the serum calcium go up.
right. Yeah. So,
Um, yeah, I mean, you could think about this is way off label, of course, but it's in a cal set, try and lower that PTH. But what impact that would have on the urine calcium? It might raise it.
right.
Um, hard to predict.
So I'm going to finish working her up and then I'll follow up with you. Um, maybe you and Clemens, because this is seems like an interesting story. And
Yeah, I'd love to know the end of the story.
so anyone else have some questions or thoughts before we go to the next case?